This conference will now be recorded.
Welcome everyone, welcome September champions. And here is the possible career opportunity after part 1 MRCOG. Okay, inshallah, you will pass your exam and then you will have those opportunities. The possibility number 1 is you set for the part 2 MRCOG. Okay, apparently. And I would recommend that if you have some experience, okay, and you have spent some time in your obs-gynae career. If you are starting your career still, so I would suggest, and you are interested to work in the UK, I would suggest you go for the MTI pathway. So MTI pathway, just language evidence certificate, either the OET or the IELTS one. Okay, so you can apply for the MTI. You know that the MTI was actually was held because of the COVID circumstances the last 2 years, this year to 2021 and the previous one as well. So what happened, there is a good news on the way, okay, that the college, because they have demand and they have shortage in number of junior doctors, okay, so they are now have increased number the need and the MTI 2022, okay, and they will announce the details by this September 2021, okay. So if you are interested to work in the UK and you are planning to set your exam for this September, okay, I would suggest that you always check the website of the Royal College, and of course I will post the details, okay, for the MTI announcement, because they have timeline for the announcement, so I don't want you to miss it. Okay, guys, so this is for the MTI news, okay, and this news is, I think it's a very good one. If I'm going to discuss with you um, the study plan, okay, so first you have to make sure that you know uh, all the necessary information about the exam format and what you expect to find in the exam. Okay, so you know that this is a September, January, July. This is number 4 in the computer-based test. Okay, this coming September exam. So you will have 2 papers on the computer. So it's very much like our website. You will find 100 question and you have to finish them in 2.5 or 2 hours and a half. Okay, so this is a single best answer form of the questions. It is easier than the eMRCOG, of course, in the part 2, but still a little bit tricky. Okay, so you have to be trained on how to choose the appropriate words, okay, or the appropriate answer based on the given information to you. You have to be precise as well, okay, so you will have to read the lead in the question twice at least, okay, so you see what is in the sentence, okay, of the question, and you be directed to the correct answer based on what is written there. So when I ask you a question, I will give you the same scenario, but just I will write down there, I need the initial management. Then initial management means that the first thing you will do right now, okay, or the next thing that you will do for that patient, different from appropriate management or recommended management. And we will see with the question how this will affect your answer. Okay, it's very important. You will have 200 questions in total, 100 question in one paper and 100 question in the second paper with 1 hour break. Okay, this blueprint from the Royal College, okay, which shows the division of marks, okay, and I can say that there is overlap between the modules, okay, or the chapters, but you have to put this as a guidance for you. Okay, so you have to put in mind in paper 1, you will see the big portion is for the anatomy and the endocrinology. Okay, so this is actually carry more than 50% of the questions. What's here? This is the physiology one, okay, and this one for the statistics. So the part of statistics is not easy one, okay. So you will see, yeah, it has a good portion there. That's why we covered this statistics in 1 hour in our in one session in our course, okay, for the common questions in statistics and how are you going to approach them, okay. For the anatomy, okay, it's very important that you know the basic anatomy for the female reproductive tract, the pelvis, and also the fetal skull as well for the obstetric. So you know this thing. What's very important in the anatomy? The very important thing in the anatomy is the applied anatomy. Means that if you have the nerve injury, vascular injury, this is a very important thing. If you have any important landmarking, okay, this is another important thing in the question. So when you study the anatomy, make sure that you have the notes, okay, of the anatomy. This will be done by Dr. Ahmed. And you will have this table from the nerve injury to article. Okay, this is a article published by the obstetrician and gynecologist journal, okay, by the college. So this article is very important to you. Okay, common anatomy question ask about the vascular injury, for example. This is comes from the guideline of preventing entry-related injuries of laparoscopic surgery. Okay, so they will ask you about, like, for example, secondary port insertion, okay, of the trocars. So what is the most common artery to be injured in this phase, okay, or at the primary insertion in a very thin patient, what is the most common arterial injury in this case? This is very important, okay, point. So we will, along with a new article has been released last year, okay, about the vascular injury as well, so in laparoscopic surgery. So this is a very important parts, okay. So that's why you will see like overlap between the anatomy and the clinical management itself, okay. So will you study anatomy from other book or textbook or something like that? No, I would not recommend that, okay. The notes of Dr. Ahmed is more than enough actually for the anatomy, and he had a very high quality version of it, okay. So you will depend on the notes and the questions. Are you going to solve the questions in any book? I would recommend first to go to the website, our website, the eMRCOG, and then you can practice whatever books you need, okay? And it's a good opportunity also to announce that we are going to solve books, okay, on a daily basis on our Part 1 free MOOC group, okay? So you also follow the schedule there for solving the books, practice books, okay, because it's full actually of outdated or wrong answers, okay. This is the sad thing about it. I'll tell you something, I'll tell you a secret. Today I was revising the RCOG website itself, okay. There is sample of the question has been provided, okay, by the college. Those samples of the question, they are there since long time, they are not updated, okay. So there is 7 questions or 8 questions, 3 of them are outdated answers on the RCOG website itself, okay. So guys, careful. You will tell me this is the answer provided by or found in the sample of the RCOG website. I would reply, okay, that guys, even if this is the answer, okay, no, in the exam has reference, okay, and every question is there in the exam, it will be bounded by its reference, and the reference is the updated form of reference, okay. So you have always to do that. This is the secret to success from Part 1 to Part 3. Don't follow any key, just go to the main reference and check the information, okay. So This is for the anatomy thing. The endocrinology will be covered by Dr. Rana, okay? And also most of the information from the endocrinology, actually, it has overlap with the gynae problems. Like, for example, when we speak about the primary amenorrhea causes, okay? Or even secondary amenorrhea, the role of hormones are there. When we speak about PCOS, okay, and the fertility problems or the hirsutism problems, you will find the base in the endocrinology. So you will find here in paper 1 questions about PCOS or hirsutism or secondary amenorrhea or primary amenorrhea. So this is basic science, but came in the applied form. Okay, so this is also my advice to you guys. You have to understand the base or the pathophysiology of the disease, okay, and its physiology parts. Okay, the physiological changes in pregnancy is super important topic in your exam. Okay, and I will tell you about one actually it's very interesting guideline. It's the maternal collapse. Okay, so the maternal management of the maternal collapse starts by describing the changes that happen normally or physiologically in pregnancy. Okay, and the same as the update in the sepsis update in 2020. It's a TUG article. Also, it gives you the same thing, okay, and the famous infographics that show you the physiological summary of the physiological changes in pregnancy. Okay, so guys, I need you to have a look to those, okay, because you will find questions in the physiology comes from these guidelines, ask you about which increase in the pregnancy, okay, which decrease and what is this effect, okay, like for example the heart rate. What do you think, heart rate increase or decrease? What do you think? Increase, decrease? Cardiac output, increase, decrease? What do you think, guys?
Increase.
Of course, it's increase. Yes, excellent. So plasma level also increase, okay? And you should know how much is the percentage of the increasement, okay? So what is the only thing that fall during pregnancy? The only thing that fall during pregnancy is
Hemoglobin.
it's a physiological, it's a relatively, okay, that's why we will see this physiological anemia.
Hemoglobin dropped during pregnancy.
Yeah, hemoglobin dropped during pregnancy. That's because of the increase of the plasma level. So it's not a real drop. It's only a physiological anemia, physiological type of anemia. Okay, actually the vascular resistance, okay, is the only thing that really decrease in pregnancy. Okay, so we will see those numbers. Those values are very important. I'm going to send you this infographics today, guys. You have to read it. Okay, of course it will be included in the notes of the physiology, but you have to remember it by heart, okay, because we have topics that related to the physiological changes in pregnancy, okay, and you have to differentiate between the disease and the physiology, like the cardiac disease. Okay, so if I ask you guys about the most important information about the cardiac disease in pregnancy, so do you think it contribute to maternal death or not? Yes or no? Do you think cardiac disease? Yes. Yes, sure. So if I ask about the most common cause of maternal death.
Cardiac disease.
Yes, excellent. It's the cardiac disease. Actually, maternal death it is divided into the causes. Direct causes means it's related to pregnancy, and indirect causes. Indirect causes, that mean a woman has the medical disease, but pregnancy cause deterioration of this disease leads to finally death. Okay, so the indirect causes is the most common causes, and on top of it is the cardiac disease. And actually cardiac disease alone contribute to 23% of cases of maternal death. Okay, so very high. And the thing is that the women, when they present, they found that large number of women, they have no history of cardiac disease, but the first time they discover or they come to know that they have the cardiac disease actually is during pregnancy. That's why, because the pregnancy with the increased plasma volume put some strain on the heart. Okay, so if there is some defect and before it was compensated, okay, so in pregnancy it will be decompensation, and this is very common in the first trimester, actually toward its end, and in the immediate postpartum period. Okay, so we will find that the woman will suffer or manifest their cardiac problem during pregnancy. Okay, but in the same time, guys, the physiological changes of pregnancy from the cardiac, okay, problems like increase of the heart rate, okay, the tachycardia that's seen in pregnancy. The pregnant woman, they will be a little bit dizzy, okay, they have increase also of respiratory rate, okay. So you may have a patient presented to you with early signs of cardiac disease, but you think that this is the physiological changes of pregnancy. That's why it's too risky, and that's why the college put a very important, okay, spot on this topic, that you have to know the physiological changes. So when the woman comes to you in a state of a disease like the cardiac disease or sepsis, because I will come to sepsis today and explain it to you, okay, the changes that we see in sepsis or the changes we see in the postpartum hemorrhage, the early changes, okay, that may be mistaken at the early stages by the physiological changes. So it's very important that you differentiate, be able to differentiate between the both of them, the physiological changes of pregnancy and the pathological changes, especially early phases, okay, before the patient deteriorate. Okay, so if we speak about cardiac disease, postpartum hemorrhage, okay, and maternal sepsis, they make, okay, almost half of the cases of maternal death. Okay, so that's why very important that you be able to spot the early changes on those. Okay, and that's why those questions in the exam, you know that your exam questions are not equally distributed, the marks, right? Okay, some questions, and this is the modified EPLS criteria of your exam. So some questions will have high mark and some questions will have less marks. Why? Okay, that's because they will see, actually, according to some sophisticated process, okay, what is the question, what are the questions that you cannot afford to miss, okay, in your preparation. Okay, so whenever you have a very important part or a question or a topic or information that can save the woman, the pregnant woman life, okay, then it will be important from the exam point of view as well. Okay, guys, so does this make sense? Yes, it makes sense. Okay, so I'm going to continue with you the distribution of marks, okay, in your exam, because as I told you, this is for the smart candidate. How are you going to prepare smartly? Okay, the part of the genes, this is with the orange color, the genetic problems, actually, it is related to inheritance of the disease. apparently. Okay, and we have a very lovely notes for that. Okay, the mode of inheritance of the disease. Okay, and the defect we see in the major conditions, starting by the Down, Edwards, Patau syndromes, okay, and then other conditions, other inherited disease like the thalassemia, like the sickle cell as well. The mode of inheritance are very important. So we should know the the basis of the genetic inheritance, genetic disease, and we will have some important applications from big syndromes. Okay, some syndromes like the cancer inheritance syndromes, cancer inherited genes like the BRCA1 and BRCA2. Okay, they are of super important. Why they are super important? Because simply, if you have a lady in your clinic, for example, and she had a family history of Lynch syndrome or BRCA1 gene um, in her family. Okay, so she will be so worried about her coming a baby, right? So the first and the most important question she will ask you, and you have to be able to answer this, is what are the chances that my child will get this condition, right? So that's why it's important. And that's why there is some numbers, I would say unforgettable number, okay? You will never forget those numbers in your exam. The numbers that have a very important, significant, and clinical impact, okay? Like a woman, she had before a cesarean section. Now this is the second pregnancy. Okay, she will ask you, what are my chances, okay, to have a vaginal birth? So you as a doctor will have to be able to answer this, right? You have to be able to tell her what are her chances. For example, one lady, Miss X, she is um, multipara, okay? She had two successful vaginal deliveries before, but she got the third baby by cesarean section because of breech delivery, okay? So what is the chances for the next time that she will have a successful vaginal delivery?
Until 90,
Yes,
19%.
90%. Yes, excellent. So 9 in 10, okay, those are the chances for her. So she had a good, okay, chance that she will go for a vaginal birth, a smooth vaginal birth. So it's good that you tell her this number. If you have another woman, we will say Miss Y. Okay, Miss Y, she had a high BMI. Her BMI is 40. Okay, and during her first baby delivery, there was non-progressive labor. Okay, and they had to take the baby for an emergency cesarean section. And okay, now she's asking you in this second pregnancy, okay, what are my chances? So we have the cause of the first previous cesarean is non-progressive labor, okay? And we have another problem that she had a high BMI, actually 40 of the BMI. So this may indicate that she had inadequate pelvis, right? So do you think that she had a similar success rate of Miss X, the multipara that she had on the cesarean section because of malpresentation? No, she doesn't. Okay, actually, it's lower. Lower by how much? What does the guidelines say? The guidelines say
80
actually,
to 85.
no, Dr. Dina, this time it's much lower. It's actually 60%. Okay, and with the BMI as a factor, it may be, okay, less than even 60. Okay, so combination of factor will make it even less than 60%. Okay, so this is a chance like she had Yes, Dr. Hassan, of course, it's included in the course. So we have chances, okay, different chances for the success, okay. So this is very important information because it will make the woman think, okay, so the doctor now said I have two risk factors. One is the previous non-progress of labor, or the baby was not happy during labor, means fetal distress. And also I have a high BMI, so my chances is maybe 1 in 2. Okay, no, I'm not going to take the chance. I will go for a cesarean section. Okay, so this is how numbers will affect the patient decision. Okay, so this is one of the important numbers and one of the important topics or tables that I'm going to give you as well. Okay, so you be smart and focus on the important repeated topics that make a significant, okay, difference in your patient care, right? Because if you know the training in the UK, the training system, you know that a trainee on ST2 level in the training, and I would say that the training is divided into from ST1 to ST7, okay? On ST2, he must pass the Part1 MRCOG. He cannot go to the next level in the training in the ST3 level, okay, without passing this MRCOG, Part 1. So that means he cannot take a second call without this MRCOG, Part 1. That's very important. This is a turning point in the career, okay, for the trainee. So you have to know how to take the decision, or what is the important decision. That's why the question comes with this clinical, taste or flavor, even those with the basic science. So it's not only all basic science is important as well, but also basic science that's related to important topic in practice, right? In the part of embryology, actually, it will be included with anatomy and understanding the embryology and the origin, okay, of each system is very important. Like, for example, if they ask you a question about Mullerian agenesis, how does this relate to the practice? What do you think when we say Mullerian agenesis? You think that the patient with Mullerian agenesis will have uterus? What do you think, guys? Okay, another question to make you just think of it. Do you think that you will have... Yes, I'm asking about Mullerian agenesis. If there is a Mullerian agenesis, what do you think the patient will present with? You think the patient will present
according to which type?
Primary.
Which classes? Are there class 1, class 2, class 3, class 4? If
yeah.
she is like she's having bicornuate or septate uterus, she is more like to have recurrent miscarriages, breech presentation.
Okay, yeah, thank you very much. So the Mullerian agenesis, thank you very much, Dr. Hassan, that's known as the Mayer-Rokitansky-Kuster-Hauser syndrome, or MRKH, okay?
Primary amenorrhea.
we see, yes, we see clinical presentation with the primary amenorrhea, and also we will see sometimes vaginal agenesis. Okay, so the patient will have a congenital malformation. Okay, that's because of the failure of the Mullerian duct to develop. Okay, so that will result in missing uterus and a variable degree of the vaginal hypoplasia of the upper portion, as well as we will see a renal tract abnormality in 40% on those patients. Okay, so just understanding the relation would make sense in the clinical practice, right? So that's why they ask you, you are a doctor, you're preparing to be a registrar in obs-gynae, okay? So that's why they ask you those basic information, okay? Because everything makes sense in the practice. If we move to the paper 2, we will have in paper 2 the big topics. What are the big topics? Big topics are the data interpretation, the pathology, okay, and we will have the pharmacology. Okay, so it makes sense. Data interpretation, your ability to read the CTG, ECG as well, okay, because we speak about cardiac conditions, very important. Okay, so if the patient presented with dyspnea, you have to be able to diagnose what is the problem with her. Okay, maybe your patient has a BE, maybe your patient has MI, you don't know. Okay, so you have to be able to read the ECG, very important. You have to be able to read the CTG, because based on the CTG you will take decisions in labor, either to continue or not, go to cesarean section, so according to your interpretation. The fetal blood sampling, very important, because in the fetal blood sampling, it's the same thing. If you have a pathological CTG and you have performed in the first stage, you have performed the fetal blood sampling, and the fetal blood sampling number, for example, came as 7.1. So what will be the action now? Good doctor will know that this is acidosis, and below 7.2 we have to run to theater, okay, because baby will be hypoxic and in distress, right? While if you have the value of 7.27, for example, so 7.27, that's mean you still have a time. Okay, so you continue with the observation of a CTG, and then if the CTG continues the same, you need to repeat it, okay, within 1 hour. So this is a different, totally different management based on a number. So interpretation of the fetal blood sampling, interpretation of the CTG are very important for labor management. Interpretation of the ECG or ABG, okay, the arterial black gases, are also very important in your emergency management. Okay, it can save lives. Okay, so this is a type of knowledge, okay, that equal patient life. So this is something to appreciate, not only for the exam, it's for your life, guys, as a doctors, as a lifesavers, as superheroes, right? So this is our tools, guys, is the knowledge. So we have to have this knowledge, okay, for a safe practice. What else comes? Data interpretation. Yeah, pharmacology. This is the drugs apparently we describe for the patient. So we have to know how does it work. And the part of the clinical management, actually, it's, you know, see it here in red. Okay, so if you are smart enough, you will know that every single point that I mentioned here, okay, has its own clinical application. So the clinical management part is very big, okay? It is not this only small part, okay? So in the clinical management, we will discuss the important point or the important cases that you need to be aware of its management and its contribution of the exam. Actually, I would say that this is not true. Okay, the paper 2 will, you will have more than half of its cases from the clinical or the applied clinical knowledge, as well as a good portion in the part 2 paper 1. Okay, so very important that you know the clinical management very well. And to be honest, okay, the questions in the clinical management usually comes easy and it has a high mark, okay, in the mark sheets. While the question on the basic science, sometimes they ask you some questions and you will forget about it. Like, for example, they ask you something about embryology. This is for you a pure theoretical knowledge. So, oh my God, I forgot this information. I'm in doubt. No, I'm not sure. Okay. So you will just put what you think it's right. Okay. My hunches say B is correct. So I will put B and go. This is what's happening in exam. But in the clinical management or the applied knowledge, the good thing is that I know you are a decent doctors. You can have a good decision and the correct decision, even if you know nothing about this topic. Okay, you didn't study this topic for the eMRCOG, I mean. Okay, but you will know it from the practice, from your clinical judgment. Okay, so you can get the correct answer. The microbiology part here, it's actually infections. Okay, fetal infections, sexually transmitted infections. Okay, some organisms that cause recurrent UTIs or can cause sepsis, maternal sepsis. So this is what we see in the microbiology. In the pathology part, we will see the pathophysiology of some disease, especially oncology or this related to tumors. Okay, and it is also, I told you, it's all related to the clinical management. So if you are able to understand the main topic in the clinical management, you will get this questions very easy, actually. Okay, so this is what we are going to cover, okay, according to the syllabus, and this is how are you going to plan your study. And this is our schedule of the course, okay? So actually, my part in this course is just the obstetric part, okay, and the labor management. And my friends here, Dr. Ahmed, Dr. Rana, and Dr. Nada, they are doing very good job, okay, in the other sessions, okay. The sessions following will be by Dr. Ahmed, and it will be a very important sessions that I will advise everyone to attend. You never missed the anatomy statistics part, okay, or the genetic part as well. Okay, so what I'm going to cover with you, we have in the clinical management or in the obstetric problems, we have two main sources of a study. Okay, so what are the two main sources we have? They are the GTG guidelines and the NICE guidelines. Okay, so the green top guidelines, they are found on the RCOG website. Yes, Dr. Hassan, it will be recorded. And NICE guidelines were found on the NICE website. Okay, in the NICE guideline, there is actually very, 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 okay, lovely way to study the NICE guideline through it. It's the NICE Plus way. Okay, so you just click to the NICE guideline, go to the website, you will write, for example, NICE guideline of intrapartum, or like, for example, for ectopic pregnancy. Okay, just click on that, you will see pathway, what's written there, pathway. Go to the pathway or click the pathway and you will find how are you going to arrange your mind, okay, and you will find a good pathway to go through it or can help you in the clinical management. So this is very important, mainly for part 2 exam, mainly for your practice. Okay, for part 1 exam, don't worry, I'm going to cover this or the important point for you, and this is we have our special notes for that. The green top guidelines, you need to go through them. Actually, you need to read them at least once. In the green top guideline, if you go to the guideline itself, you will find some recommendation summary, okay, and you will find after that some details. Okay, in the recommendation summary, here at the website MRCOG website. So I'm going to give you example how are you going to go through that. Here in the green top guideline, for example, here is the gestational trophoblastic disease, or the assisted vaginal birth, or the maternal collapse. Okay, actually those are very important, very important that you understand how to go through them, and you have to read them at least once. And the recent guideline will make a good contribution of your exams, both part 1, 2, and even 3. Okay, so I'm going to click here on this guideline and let's see how it comes. Okay, so this is the executive summary, okay, about what is the recommendation, the levels of recommendation, and how do molar pregnancy present to the clinician. Okay, so the presentation or the symptoms, you should know something like that. So here comes the question. The most common presentation is irregular vaginal bleeding. Okay, so this is make one single best answer question. Ask you simply the most common presentation of molar pregnancy is, and he will give you choices. You know now for sure that the correct answer is irregular vaginal bleeding, right? This is for example, okay? So you go to the grade of recommendation, you have to read them carefully, highlight the important point. Like for example here, this is one point. What is the best method for removal of molar pregnancy? So here comes the answer, clear. As clear as the sun, okay? So suction curettage is the method of choice for removal of complete molar pregnancy. You got it, guys? So those parts, okay, are important. It make your exam easy, very easy. If I ask you about the anti-D, a woman, he will give you a long scenario about Miss XY. She had this and that. Her pregnancy is 10 weeks and she found to be molar, suction and curettage done. Okay, so the question, her AB, her blood group is AB negative. Does she need anti-D prophylaxis? The answer is clear now. Anti-D prophylaxis recommended following removal of a molar pregnancy. Right, guys? So here you will find the summary of the recommendation. My job actually is to discuss the questions with you because we are in the intensive course, right? So I'm going to discuss the questions with you in our next session, and we will make a good, based knowledge question and answer on the molar pregnancy. Okay, so assisted vaginal delivery, it is the same thing, and there is a new thing actually from the college. Okay, very nice thing. It's the enhanced version. This is a trial. The college actually, they have a trial. Okay, this is an audio record of the GTG, so you can enjoy it. Okay, so you can go through this actually, and they need our feedback because it's in the form of a trial. So if you just click here play, you will listen to the guidelines itself. Same thing for the maternal collapse. So I would recommend you even listen to it if you don't have time to read. Okay, guys, so this is the important guideline I'm going to cover with you from the green top. Okay, so molar pregnancy, hyperemesis, management of antepartum hemorrhage and abnormal placenta, management of postpartum hemorrhage, shoulder dystocia, vaginal delivery after the previous CS, assisted vaginal delivery, prenatal tear, breech and ECV, prevention and management of sepsis, the maternal collapse, which is a very important one, and common fetal infections. Okay, yes, it is there in the microbiology, but again, okay, we will have some question on them. You think looks like a good plan, guys, for our course? It is, believe me, it is. Okay, so example of how are we going to deliver the information in a nice way, because you have limited time apparently for the exam and you need to be smart in your preparation. So look at me, guys. This is one question, single best answer. Take your time reading this in no more than 1 minute, okay? And tell me what you think the answer is. Okay, so my turn to read the question. Okay, so I'm having this question for a 24 years old woman who had miscarriage at 9 weeks of gestation. So she had already miscarriage, friends. What happened then? Next day, she had a full blood count done. And the results are tabled below. Her blood pressure is 84/40. You think is it good? You think that this is acceptable blood pressure? No, of course no. This is very low. She is going to shock, hemorrhagic shock. Her pulse is 95 per minute. Let's see her hemoglobin. Her hemoglobin actually is 62, okay? And her YPCs are normal, 8.53. Platelet count is 264, so no problem with the platelet. Okay, so guys, and the hematocrit apparently is 0.29. Okay, so which management option is most appropriate?
Blood transfusion was 40 minutes of blood.
Yeah. So everyone agree for Dr. Marwa answer? What do you think, guys? Do you agree for Dr. Marwa answer? Thank you very much, Dr. Marwa. Your answer is correct. Yes, so thank you very much. And let me remind you with the protocol of management of postpartum hemorrhage. Okay, so the full protocol of monitoring and investigation a major postpartum hemorrhage when there is a blood loss greater than 1000 ml. In this case, you think that the blood loss was more than 1000? Yes, I think so. Why? Because there is a changes in the blood pressure, okay, and the increase of the heart rate. That's mean that the woman, okay, had lost more than 40% actually of her blood. Okay, so immediate venipuncture, okay, by 2 large bore cannulas, okay. We will have some blood also, like 20 ml for the cross match, for the full blood count, for the coagulation screen, and this will include fibrinogen test, renal and liver function test for a baseline. The temperature also would be reviewed for every 15 minutes, continuous pulse, blood pressure recording, and respiratory rate. Polycatheter, why? This is to monitor the urine output. 2 peripheral cannulas will be inserted. Consider arterial line monitoring, okay, and recording of parameters on the modified early obstetric warning score, which is the mu chart. And the mu chart, guys, this is the chart when we have all, patient charts, when we have all the observation of the patient, including even the drug that she have received, any amount of fluids, the output, everything about her vitals as well will be put in the chart, the mu chart, which has a very important and significant importance in our management for the emergency cases and pregnant women. And it's called the modified early obstetric warning score, because in the UK they use another one called NEW by N, NEW, but our one, okay, in the obs and gynae called MIU chart, which is a modified early obstetric warning score again, and it has a cutoff of 6. Okay, so whenever you have a mu score more than 6, that means you have an emergency case that necessitates immediate action. Okay, and also you alter the team, senior team, okay, and everyone should come to review this case. Acting and escalating promptly, okay, for the mu, this is very important, and documentation of the fluid balance, blood product, and procedure. This is the guideline, part of the guideline algorithm, okay, which summarize the management, okay, for the postpartum hemorrhage, starting by call for help, okay, and alerting the hematologist, alert the blood transfusion laboratory, alert the consultant obstetrician on call, okay, and ABC for the resuscitation, airway, breathing, circulation. You put the oxygen mask, 15 liter means fluid balance. You start resuscitation till the blood is ready, okay, by 2 liter of isotonic crystallide. This is a single best answer question, and then followed by 1.5 colloid. Okay, this is till the blood is ready. Once you have the blood is ready, then stop the fluid management. Blood transfusion is if you don't have the specific group matched blood, okay, you can give O negative blood, right? Other blood product that can be also needed for a major obstetric hemorrhage are full fresh frozen plasma, platelets, cryoprecipitate, or factor 7A, okay, and very important to keep the patient warm. This is for the resuscitation of the postpartum hemorrhage. This is something, guys, you should know by heart, okay, for the single best answer and for your patient safety in real life and for part 2 exam in the eMRCOG. Okay, so this is a super important topic at all levels. Then comes the part of the medical management of the case. Medical treatment for a case of postpartum hemorrhage. This is not applied for our question. Our question has been answered already by Dr. Marwa that we need in the resuscitation we need blood units, okay, blood transfusion for at least 4 units to be ready for us. Okay, so the medical treatment, wrap up the uterine fundus if you have a postpartum hemorrhage after delivery, empty the bladder, you offer oxytocin 5 international unit, slowly IV, you can repeat it if necessary. What is the next drug to be given? It's ergometrine. Can anybody tell me what is the problem or the safety thing that you need to put in mind for the ergometrine?
Hypertension, contraindication.
Yes, excellent, Dr. Marwa. It's the hypertension. Hypertension is a contraindication to use the ergometrine. Oxytocin infusion, okay, will be also used for the postpartum hemorrhage after delivery in the form of 40 international unit in 500 ml. Okay, carboprost as well can be given. What are the contraindication of giving carboprost? Carboprost is a prostaglandin, right? Yes, excellent. Bronchial asthma. Yes, excellent, Dr. Hassan. So it's 0.25 mg, the dose, given IM, and it's repeated every 15 minutes up to 8 times. The carboprost, okay, can be given intramyometral, okay, 0.5 mg. Misoprostol, it's very effective in the management of postpartum hemorrhage, 800 microgram sublingual, and consider always the tranexamic acid in case of any active bleeding. Okay, so the tranexamic acid will be as 1 gram IV to give into the patient. Okay, so the medical management of postpartum hemorrhage is very important. The resuscitation for the postpartum hemorrhage or hemorrhagic shock is very important as well, guys. You remember the ABCs and what are the drugs to be given. Moving to the next question. Okay. A 24-year-old presented at 27 weeks into second pregnancy. She is feeling unwell with backache, fever, and rigors. She had a temperature of 39.5. Urine analysis shows leukocytes and protein 3+. Her blood pressure is 80/50. Okay, so which action is most appropriate now for her?
Admit to ICU for intravenous antibiotic and supportive care.
Thank you, Dr. Marwa. So guys, what is your diagnosis from the given information? The diagnosis from the given information, this is, yes, thank you, Dr. Marwa. Yeah, this is a sepsis, right? You suspect a sepsis. This is a serious condition, right? Because the patient had, yeah, she had low blood pressure, she had fever, okay, and she had evidence of infection. Okay, so once we have this, so we have to think of sepsis. When we think of the sepsis, what are the important action to be taken? There is 6 bundle, okay, the sepsis 6 bundle that we need to deliver within 1 hour of the patient presentation to us. First is oxygen therapy, okay, so you need to maintain the oxygen saturation for the patient above 94, okay, and you will collect blood culture, okay, for the patient at the time she presented, and also we will take culture from whatever place we think it is the source of infection. For example, if a patient comes to you after cesarean section and you see that there is a wound infection, so you need a wound swab, right? If you think that patient presented after miscarriage and she had offensive vaginal discharge, so we need a vaginal swab. If the patient presented like that with a UTI, so we need to collect the urine for culture and sensitivity as well, right? So it's not only the blood culture, actually we will take also other form of cultures from any place that you suspect will be the source of the sepsis. We will start the antibiotic, and of course blood culture always comes before the antibiotic. We will also start the fluid resuscitation, and the fluid resuscitation for sepsis is very also important. What type of fluid you will give? Will you offer a patient with sepsis a colloid or a crystalloid fluid? In resuscitation, we always start with, okay.
Crystalloid.
Yes, excellent, Dr. Hassan. It's a crystalloid. We offer the crystalloid. The colloid has a large particles, right? And it has its own principles, risk, like the kidney injury, for example. It has its use, okay? But first, in the resuscitation, we always offer the crystalloid. Some question, especially there is one question on strategy, ask you about the specific name, okay, of the fluid that you would prefer in management of sepsis. And I would say the Hartmann solution is good as a start, okay? So the rate also is important. We can't give volume overload to a pregnant woman, right? especially if she's in a critical condition like sepsis. So we have to have a controlled rate of the fluid management. It should be no more than 30 ml, okay, of IV fluids. Ideally, it will be from 20, actually, ml per kg, whatever you have to maintain the intravascular pressure of that patient, okay? We need to check the lactate level as well in the sepsis case, okay? So the lactate level, we have a critical number of lactate that indicate septic shock for the patient. What is this number, guys? It's a very common exam question. Ask about the level of lactate.
4.
It's 4, yes. So lactate level more than 4 will indicate septic shock, while a lactate level more than 2 indicate severe sepsis. And there is a definition different in the management of both conditions, because severe sepsis is not the same like septic shock. Can anybody tell me what is the difference, guys, between severe sepsis and septic shock other than the lactate level?
Hypotension.
Yeah, both actually will present with hypotension. Thank you, Dr. Marwa. So, but the thing is,
In organ failure.
Organ failure, yes,
Organ.
it's one of the indications that you have a septic shock. Yes. So the very important, guys, difference in the management of severe sepsis and septic shock is actually septic shock means that there is hypotension despite of resuscitation. So you have, okay, yeah, thank you very much, Dia. So you have started your resuscitation, okay, but there is no response. Still, there is a hypotension. And once we have reached this level, okay, that's mean we will need specific drugs that can help us to maintain the blood pressure. And this is given only in the ICU. What is the name of these drugs? A specific group of drugs. I would say vasopressor. You think that we need a vasopressor at this level? Yes, we will need it, okay? And very important to maintain the blood pressure in this case and using the CVP as well. So the patient will be in the ICU under the care of anesthetist and intensive care doctors, okay? So they maintain the organ function and they maintain the blood pressure using drugs, not only by the fluid resuscitation, okay? So this is actually the pathogenesis of sepsis. It has its underlining, you know, theory of what's happening on the cellular level, okay, because of the vast amount of the neurotransmitter and toxins, okay, that cause the vasodilatation. That's why the patient cannot return her blood pressure despite of the resuscitation. This is from the TUG article, okay, the update in sepsis management, and this is the clinical features of sepsis. The clinical features is important, okay, when you see a case like that to suspect sepsis, because whenever you suspect sepsis, you have to act fast, okay? So the tachycardia more than 100, okay, and if the patient is in labor, we will consider it more than 110. Tachypnea, okay, once we have a respiratory rate more than 20, or hypoxia with O2 saturation less than 94% on air, systolic hypotension, okay, blood pressure less than 100, oliguria, when we have a urine output less than 0.5, ml per kg per hour for 2 hours. Okay, so guys, careful from this number. 0.5 ml per kg per hour. That's mean if you have a patient and she is 90 kg, what will be the definition of oliguria of her? After 2 hours, you find in her urine bag urine amount of less than. Okay, so if we count, yeah, so if we count 0.5 per kg per hour, that's mean 45 ml per hour, right? So in 2 hours, we have 90, right? So it is the same like her weight, right? Less than 90 ml for her, okay? Well-defined oliguria, okay? Rigors or temperature less than 36. So guys, hypothermia is dangerous as well as fever. Okay, so if the patient has a fever, this is a good thing or a bad thing? High fever is a bad thing. It's an indication of infection. Hypothermia as well. If the patient temperature is less than 36, you think that this is a good sign or a bad sign?
That's
It
fine.
is bad. Yes, it is bad, and actually it necessitates, okay, ICU admission. The hypothermia, one of the indication of ICU admission. It is the same as in the organ failure. Okay. So, abdominal pain or distension, offensive vaginal discharge, urinary symptoms, productive cup, those are the signs that make you think that there is a proof of infection, there is a source of infection, plus the problem or the defect in the blood pressure, plus the problem with the respiration, reduce of the oxygen saturation, okay, plus the oliguria. So this is makes the picture, okay, the big picture of the sepsis. And this is the WHO, okay, actually flyer. It's about the maternal sepsis, so you should think like that and act fast. Okay, what is the maternal sepsis? Maternal sepsis is life-threatening condition defined as organ dysfunction resulting from infection. Okay, so this is during pregnancy, childbirth, post-abortion, and postpartum period. Who is at risk? Okay, it is our maternal patient, like pregnant woman who has miscarriage, abortion, or after birth, right? So what are the signs? Sepsis can make many forms like fever or hypothermia, plus any of the following: fast heartbeat, low blood pressure, respiratory distress, jaundice, okay, and decreased urination, which is the oliguria, and altered mental status. The altered mental status are very important, so you have to act fast and stop this sepsis. Acting fast means that you act within 1 hour. What you need to do in this 1 hour, you need to cover the sepsis 6 plus 1. Who is the one? We have covered the sepsis 6, right? What are the 6 steps we need to do it? Again, oxygen, cultures, antibiotic, fluid resuscitation, lactate measurement, urine output, okay? Finally, there is one, because we say sepsis 6 plus 1. Who is the one? The one is the fetus, if we speak about a pregnant woman, right? So if you have a woman presented with infection and she is pregnant after 24 weeks, what you need to do now? You should put in mind that there is another person there, right? So you have to continue CTG for the baby, right? Delivery will be expedited if there is chorioamnitis, okay? Or there is no improvement in general condition, even if the woman has any other form of infection. Like what? like the iatrogenic preterm birth with COVID patient. The patient who had a COVID infection, okay, that's severe enough to put her into mechanical ventilation, we need to deliver this patient or not? If the patient had her infection so severe, do you need to deliver her or not?
Deliver.
Yes, you will deliver her in order to help, okay, her system to recover, right? And also you can have a shot with the baby, you can save the baby. And in the maternal collapse, there is very important part in your resuscitation for the baby. In the maternal collapse, you have a very important part in the resuscitation of baby called the peripartum cesarean section, right? Perimortem cesarean section, right? Okay, so why you are doing this cesarean section? If a woman had collapse, failure to respond to that collapse, then you have to do in 4 minutes a cesarean section, right? The perimortem cesarean section. Is it for saving the baby or helping the mother? It is actually for helping the mother. Okay, so this will help her to restore her vascular, okay, circulation, and to help her oxygen saturation and better for her resuscitation as well. That's why we need to deliver the patient, okay, after 4 minutes of collapse and no response. Is this information looks new for you guys? The perimortem cesarean section?
No.
Okay, good. Okay, guys, so single best answer number 3, where in the body is angiotensin 1 converted to angiotensin 2 under the influence of angiotensin converting enzyme?
PD.
So guys, no problem, you can guess the answer, write it in the chat box if you'd like to. You don't have any problem to make mistakes now, because apparently we are not in the exam. So try, answer, okay? Okay, actually guys, okay, this is the system and those are the organ involvement, okay? Can you see this diagram? Okay, so at what level the angiotensin 1 converted to angiotensin 2?
Lung.
Yes, it is at the lung, okay? So I guess after this diagram, we should not forget, okay, the steps. So conversion of angiotensin 1 to 2 happened in the lung. Okay, guys. So angiotensin 2 effect on the blood. Can you please tell me 2 of its effect, angiotensin 2? Okay, I'm going to ask you, vasoconstriction or vasodilatation?
Vasoconstriction.
Yes, sure, vasoconstriction, increase in the blood pressure, right? Sympathomimetic or sympatholytic activity?
Sympatholytic.
It's sympathetic activity, increase the sympathetic activity and increase the blood pressure and cause vasoconstriction. Would cause salt and water retention or not?
Cause salt and water retention.
Yeah, so if you have a patient with high blood pressure, she's not pregnant, because apparently ACE inhibitor in pregnancy is contraindicated. Okay, so if you have a patient non-pregnant and she is on ACE inhibitor, so ACE inhibitor here, okay, you blocked this step, okay, so this will result in no angiotensin II. So this will mean vasodilatation, lower blood pressure, decrease sympathetic activity, decrease urine salt and water retention, right? Right, guys? So this is how the ACE acting, and this is the idea behind the ACE inhibitors, the famous antihypertensive agent that for you as an obstetrician gynecologist, you need to remember that ACE inhibitors, okay, are contraindicated in pregnancy. Okay, so very important for you, this information in the pharmacology. So this is how we make combination, guys, between theory, application, and pharmacology or applied clinical knowledge. Okay, so I'm going to ask you another question about the chromosome contains a gene that codes for alpha globin chain. Which chromosome have the genes that code for alpha globin chain? Can you see, guys, here? This is the hemoglobin structure. You have 2 alpha, 2 beta subunits, you have the heme, right? So if you have a defect in alpha chain production, which chromosome is responsible for that? Okay, for alpha globin regulated by which chromosome? 16. Okay, because 16 will have the HbA1 gene. This is the gene that provide instruction for making the protein that's called alpha globin. Okay, so this protein is also produced from another gene called HbA2. Both of them, okay, are found on the chromosome 16. So remember, alpha globin found on 16. It is regulated by 2 genes, HbA1 and HbA2. Okay, this is actually known by alpha globin locus. Okay, so if you have a deletion or a defect on those genes, the HbA1 or 2, this will cause alpha thalassemia disease. Okay, so it came from here. It came because of this chromosomal defect. If I ask you about beta thalassemia, people with beta thalassemia, they have a defect in gene called HBB gene. This is located in which chromosome? This is 11. Okay, so I need you just remember, I know a little bit theory, okay, or actually so much of theory, but it's important. Thalassemia management, alpha and beta thalassemia management in pregnancy is very important. So this is part of the underlying causes or understanding the problem of that disease and the gene inheritance. Okay, guys, so you got this point? Will you remember this? This looks like a flashcard with two shiny colors, highlighted information. Okay, so chromosome 16 for alpha or beta? 16 for alpha, beta for 11. Okay, clear, guys? This part, is it clear? I need some response. You can write in the chat box. Hello, am I alone here?
Clear.
Okay, so no problem. I understand this is your first session with me, so maybe you didn't get to use my way. Okay, but okay, thank you very much, dear. So guys, again, this is the hemoglobin structure, and this one is going to be helpful in your exam. Okay, so if you want to just remember the alpha thalassemia, it's genetic. Okay, so patient who had one defect in one of the alpha chains will be having symptoms or not. One chain is defected, alpha. No, not symptomatic. They will have no symptoms. People who have two alpha defects, they will be asymptomatic and they will have mild form of anemia. Why this is important? I will tell you this is important why. Because actually in the guideline of antenatal care, the routine antenatal care, start by the part of booking, okay, investigation. We ask every pregnant woman, okay, for some blood test. This blood test include a full blood count. In the full blood count, we look to one of the parameters, not only the hemoglobin, we look for MCV, okay? And if this MCV found to be low, okay, so we suspect that this lady have what condition? Maybe she's a carrier of thalassemia. Maybe she had thalassemia trait, right? You have this clear? Okay, so if we speak about beta thalassemia, so what is the problem in a beta thalassemia? It is related to which chromosome? It's 11 again, okay? Beta thalassemia can present as beta thalassemia trait, beta thalassemia intermedia, or beta thalassemia major, right? This is a lovely slide about the inheritance and makes a very important or a very common exam question about if you have two partners, both of them, okay, carry a defective chain, one only, so they are asymptomatic, okay? They have one only gene affected. So what are the chances that they have baby affected with the disease? Okay, so I'm going to ask another easy question. What are the chances that they will have unaffected child?
25%.
Yeah, yes, it's 25%. Thank you very much. So, guys, what's happening here in this relationship? So, they have, okay, those unaffected genes, right? Both partners. So, those couple of genes can meet together, okay, here, and 25% of their siblings makes 25% of unaffected. They have all correct genes. There is a possibility that these two sets of genes, okay, meet together and they make the 25%. Okay, so it's 25% the carriers of the thalassemia. So, guys, I'm going to send you a version of the guideline summaries of the antenatal care and intrapartum care of the NICE guideline. So you have just a reading of the important point in the practice. Because believe me, no exam without those questions. You can think it's under the genes, but actually it's also in the clinical management, right? I'm also going to send you some notes for the genetics, okay? So have a look for them, for that notes. Also have a read of the inheritance of the major disease or the major conditions in the antenatal care, because we deal with the sickle cell disease and anemia. You will find the dealing of details, complication in pregnancy and how are you going to manage them. But the most important thing for part one is the inheritance of this condition and detection of carrier or identifying of a woman who is a carrier in the early antenatal journey. Okay, so we'll move to another common topic of the exam. Regarding CTG analysis, what is the accepted normal range of variability? And when we
5 to
ask about
15.
CTG, yeah. So when we ask about the
See,
CTG, we will go
5 to
to,
15.
okay, so guys, why do you think it's 5 to 15 is the correct one? When we speak about the CTG, actually, we have to refer to the NICE guideline 2017 and its CTG features and categorization. Okay, and in this guideline, because actually, guys, you will find some criteria like FIGO criteria of a CTG. You will find all the classification of the CTG by NICE, but the one in the 2017, published 2017, is the most updated one, and this is the one that you will have to answer according to it in your exam. Okay, so those tables that describe the features of the CTG are super important. If we speak about the baseline, what is the definition of a normal baseline in the CTG? And it will be considered as reassuring feature. It's 110 to 160. It will become non-reassuring if it is lower than 110, but up to 100. So 100 to 109 is non-reassuring. Or it's higher than the normal range, so 161 up to 180. Or we will say abnormal feature if you have bradycardia, so you have below 100, okay, the baseline heart rate, or tachycardia above 180. So this is regarding the baseline. If we come to the baseline variability, the beat to beat variability, okay, it is reassuring when it's from 5 to 25. 5 to 25. It is non-reassuring if it is low variability or reduced variability, less than 5 for 30 to 50 minutes, or more than 25 for 15 to 25 minutes. It is abnormal when we say that it's a reduced variability for more than 50 minutes or increased variability above 25 for more than 25 minutes, or it's a sinusoidal pattern, which indicate fetal anemia. Okay, so for the variability, need to remember this number is 5 to 25. This question, its source, okay, is the RCOG website itself. In what section? In the introduction or the information about Part 1 MRCOG exam. The answer of this question is still not updated, okay, because actually this information is written so many years ago, okay, and these examples of questions is still used for the exam till our day. But in exam, they will refer to the new update of the guideline, the recent one. The recent ones say that 20 to 25 is the range of normal variability. Okay, guys, so 5 to 25 is the range of the normal variability. So the answer is D. In this guideline also, the tables, which I think it's super important tables, there is need for urgent intervention. Here in this table, you will see need of urgent intervention. When you will need to do an urgent intervention, some cases when you see acute bradycardia, okay, or single prolonged deceleration for 3 minutes or more. So when you have acute bradycardia, like I will show you some examples of that, okay, like in cases of placental abruption. So this was a CTG, 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 then like that. So like that acute bradycardia, that's mean there is something acute happened, right? So what could happen in this case? You may have abruption, or you may even have a uterine rupture, right? So we need to act fast, right? So we urgently seek help, okay? If there is an acute event, for example, cord prolapse or suspected placental abruption or suspected uterine rupture, expedite birth immediately. Correct any underlying causes such as hypotension or uterine hyperstimulation. Start one or more of the conservative measures. Make preparation for an urgent birth. It's very important, okay? Talk to the woman and her birth companions about what's happening and take her preference into account. Expedite the birth if the acute bradycardia persists for 9 minutes. Okay, so this is for the acute bradycardia. Don't leave it beyond than that. If the fetal heart rate recover at any time up to 9 minutes, reassess the situation and the decision of birth. Okay, so the indication of acute or when you need urgent intervention are super important because it can save the life of the baby and save you in exam as well, right? If we speak about this table, I need to explain the CTG, and the CTG baseline consists of the baseline, the variability, and the deceleration. And the type of the deceleration is super important in your management. So some deceleration, we will consider them as a benign form of deceleration, which require no action if it is less than 90 minutes. Okay, so what is this type of deceleration that has no concern? Okay, and we can leave it up to 90 minutes without doing anything. Can anybody tell me what is this type?
Variable deceleration.
Yes, excellent. Variable deceleration, but not any type of variable deceleration, those without any concerning characters. Okay, so that's mean the question, next question is, what are the concerning characters? Okay, so what are the concerning characters, dears? What do you think? The concerning characters, okay, it is written in the same table. Okay, is not only a late deceleration or not only variable deceleration. There is a definition of the concerning characters that we need to take care of it. Okay, concerning characters mean that something indicates something wrong. So tell me, what about loss of shoulders? Look at that, guys. What do you think? This type of deceleration, is it a concerning deceleration that need urgent action, or it's the type of deceleration that we can leave for a while?
This is early deceleration, which is a benign condition. Wait.
Okay, so yes, this is an early deceleration. Why? Because the concerning characters are not present. So what are the concerning characters? Please count with me. One deceleration that lasts for more than 60 seconds. Okay, so how are you going to see if it's lasting more than 60 seconds or not? How are you going to comment? Simply, okay, this small, okay, this small one. How long does this indicate? Is it 1 minute, 2 minutes? The small square. 5 minutes, what do you think? The small squares.
10 minutes.
A small square. The small one here. Small one. It's 1 minute. Yes, excellent. So every long or larger square like this indicate 10 minutes. Let's count them together. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay, so those are 10 minutes. Each small one of them is 1 minute. So if you have a deceleration, and it will be looking like that in exam, it will be wide. Okay, so it takes like 2 squares or even more. If a wide deceleration like that lasts for more than 60 seconds, that's mean that a concerning characters of this deceleration or not? Yes, this is a concerning characters that it takes more than 1 minute. It is a prolonged, little bit prolonged deceleration. So this is a concern. Another concern is reduce the variability within the deceleration itself. Okay, so there is no heartbeat, okay, found. It is not clear in this CTG, but I will show you this one. Can you see here? Within the deceleration itself, there is a zigzag line, right? So this zigzag line, loss of it is a concerning character. So when you see a deceleration in exam like that, no zigzag line, it's straight line, okay? No variability, no beat to beat variability within the deceleration. Is that a concerning character or not? Yes, this is a concerning character when there is no variability or reduced variability. Also, in exam, if you see a CTG like this, no or reduced variability, then a deceleration like that, then like that, you think this is a good deceleration? It's a very concerning one, because in between the decelerations, there is also reduced variability. Wide means it takes longer than 60 seconds. Okay, there is also something here for excellent candidate who can tell me. Another concerning characters called loss of shouldering. Yes. So yeah, so it is normal to see shouldering. You can see there is some like that. Okay, so we see some shouldering means we see some acceleration, okay, after the deceleration. So this is called a shouldering. So if we load this one, this is a concerning character. Again, what else will make you think that there is a concerning character within the deceleration itself? If it has failure to return to the baseline, how could we prevent that? Failure to return to the baseline means this is your baseline, okay, for a long time, for example. Then you have a deceleration like this. Then it starts to recover, but oops, no recovery. It failed to return to the baseline. Then it come again like that. Then again like this. This is a failure to return to the baseline, okay, which give you the shape of which letter? Failure of return to the baseline like that. This is
blue face.
W, yes. So we will see the W shape. Okay, so W shape is one of the concerning characters as well. Okay, failure to return to the baseline. Those all are written in the table, guys, here. That's why I always admire this table and say it's a golden one for the exams. Part 1 and part 2, believe me. Okay, so here it is. Okay, the concerning characters of the variable deceleration when it's lasting more than 60 seconds, or there is reduced baseline variability within the deceleration, or there is failure to return to the baseline, or it is a biphasic shape or no shouldering. Okay, so you will take care of this table for me, guys, please. Could you do that? I need you to remember by heart this table. Okay, everything written there is a key of answer to some cases. One second. Again, the variable deceleration, if had no concern character, then I'm happy. I can leave it, but less than 90 minutes. So in exam, he will give you variable deceleration. It lasts for 40 minutes, no concerning characters. So is that indicate that you need to take any action? No, nothing. This is reassuring, no problem. Okay. But if a concerning characters appeared, then we will move from this section in the table, the reassuring, to this table, the non-reassuring, and we will see what's happening. Variable deceleration with no concerning characters for 90 minutes or more. Oh my God, that's mean if it's continued for more than 90 minutes or 90 minutes itself or up the 90 minutes, I will be worried. Yes, you should be. So variable deceleration, no concerning characters for 90 minutes or more, it's a non-reassuring. Or a variable deceleration, oh my God, with any concerning characters, in up to 50% of contractions for 30 minutes or more. So you have variable deceleration with concerning characters, continued up to 50% of the contractions, okay, for 30 minutes or more. What is your classification? It's a suspicious CTG, right? It's a non-reassuring feature, right? Okay, so how are you going to count this? Simply go back to the CTG pictures. Can you tell me, guys, about this deceleration? Is it in 50% of contractions or more? How would you know? Simply count the contractions. How many contractions are there? 1, 2, 3, 4, 5, 6, 7, 8, 9. How many deceleration are there?
7.
10. You counted 10. Okay, so I trust you. So guys, this is in more than 50%. Yes, this is almost 100%. So there is deceleration with every contraction. So if this type of a CTG continued less than 30 minutes, I will call it non-reassuring. But if it continued 30 minutes or more, I will consider it as abnormal. So first, Dr. Rabah, you said variable deceleration has no concerning characters, so we will deal with it as a benign form. Only if it is reached 90 minutes, so 1.5 hours with this deceleration unchanged, I will be worried and call it non-reassuring. Then concerning characters appeared in the deceleration. In this case, I will start to say this is a non-reassuring one. If I have non-concerning characters, then I need to look in how many of the contractions there a deceleration. So I find it less than 50% of contractions, so I can wait for 30 minutes before I say it's a pathological or anything. So non-reassuring, yes, up to 30 minutes, okay. But variable deceleration with concerning character in more than 50% of contractions, I will consider it non-reassuring. If it reaches 30 minutes, it will be abnormal. Okay? Late deceleration for less than 30 minutes and no maternal or fetal clinical risk factors such as vaginal bleeding or significant meconium, I will consider it as a non-reassuring. So late deceleration is a non-reassuring? Yes. And if you have studied CTG a long time before, this was considered as abnormal from the first instant. But now it changed. Late deceleration in over than 50% of contraction, less than 3 minutes, no maternal or fetal risk factors, I will consider non-reassuring. For variable deceleration with concerning characters in more than 50% of contraction for 30 minutes or more, this is complicated, right? Yes, I will consider it as a complicated. The lady had variable deceleration plus concerning characters, and it continued more than 50% of contractions, and it lasts for 30 minutes. No, now it's abnormal. It's abnormal, right? It can't be a normal thing. Or if you have a late deceleration that continued for 30 minutes, this is too much for a late deceleration, right? Or you have acute bradycardia or single prolonged deceleration lasting 3 minutes or more, right? So this is the features of the CTG, guys. The easiest thing is to know the baseline and the baseline variability ranges, then go to the deceleration. Okay. What do you think, guys, this CTG is? Is it normal, non-reassuring, or abnormal CTG? Or a reassuring, non-reassuring, abnormal CTG? Can you see this deceleration? Does this look a good type of a deceleration or a benign type of a deceleration? No, it doesn't.
It's a late deceleration.
Okay, so there, this deceleration, can you see its relation to the contraction? Here one, and here is another one, and here is another one, and here is another one. Do you think that this deceleration has any relation to the contraction? Because variable deceleration is a type of deceleration that has no relation to the contraction. It can happen anytime, right? While late deceleration is the type of a deceleration that its start will be after the peak of contraction. Okay, so it follow the contraction. But this one, it has no relation. Sometimes it happens the same time of contraction. Sometimes there is contraction and no deceleration. Sometimes there is deceleration but no contraction. This is a variable. Okay, so this is a variable deceleration. Do you think that there is a concerning characters or not? What about the length of this or the duration of the deceleration? See how many boxes are there? 3. So the deceleration lasts for 3 minutes and return back up, then suddenly or acutely return back down, then up, then down, then up, then down. This is failure to return to the baseline. Yeah, so we can see concerning characters there. Can you see the V shape? The W shape, sorry. It's yes, it's there. Can you see in this deceleration loss of shouldering? Yes, It is there. So this deceleration has all the type of concerns. Okay, so let me say with you, how many % of contraction? Count the contraction and count the deceleration. 1, 2, 3, 4, 5, 6, and deceleration 1, 2, 3, 4, 5. Okay, so it's less, yeah, it's around 90% of contraction. So more than 50% of contraction. So what's your diagnosis now of this CTG? How can you see it?
Abnormal.
Okay, so do you need to wait for 30 minutes to confirm? Because here you will see variable deceleration with any concerning characters in over than 50% of contraction for less than 30 minutes, right? So less than 30 minutes, I will consider it non-reassuring. 30 minutes or more, I will start to say this is abnormal, right? So here in this CTG, is it 30 minutes or more or not? Yes, this is a 30 minutes. I just beg your pardon, guys. How does this more than 30 minutes or even 30 minutes? Because we have one big box that's 10 minutes, and this is 10 minutes. We have here 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, even 11. So we have another 10 minutes here. Okay, so plus those minutes there. So this is around 35 minutes of a CTG. So of course, this is an abnormal one, right? So what action do you need to take based on that CTG?
Fetal blood sampling.
Yeah, if delivery is near, okay, so according to the stage of labor. If we are in the first stage of labor, take a fetal blood sampling, but first exclude any acute event like cord prolapse, like uterine rupture, like placental abruption, okay? Exclude any acute event like that. Then, if it is okay, if the mother is stable, no acute event, conservative management, do fetal stimulation, scalp stimulation, and then fetal blood sampling. And according to the fetal blood sampling, you take the action whether to deliver now or not. Okay, this will be the cases we discussed next time. Okay, guys. So here, what this CTG indicate? Can you see the next one?
Persistent fetal bradycardia.
Yes. So this is indicate what? Acute event happen? Do you think,
Yes.
guys? So this is acute event happening, right? Lead to this acute bradycardia of the fetus. This is need urgent delivery or not?
Need urgent delivery.
Yes, this is need urgent delivery. Okay, guys, so what is this CTG? I will just show you this part of the CTG because it's very clear. What is a CTG?
Sinusoidal.
Yes, guys. So this is the sinusoidal pattern of the CTG. And guys, the sinusoidal pattern of the CTG is a flat short-term variability, and it's will be from 5 to 15, okay, and no acceleration. And if it is mild, that will be due to a sedation, the mother had sedation, or marked due to fetal anemia. Okay, so just spot diagnosis. This is a sinusoidal pattern of the CTG. Okay, guys, so let's continue our questions. Okay. My question is not written here now. My question to you guys, absence of acceleration. Does this mean suspicious CTG or a pathological CTG or a normal CTG? Only absence of deceleration.
Normal.
Yes, thank you very much. So a deceleration, when it is present, this is a good thing. This is a reassuring thing. But its absence alone doesn't mean anything as well. Okay, so if it is alone, only no acceleration in the CTG, so no problem. Okay, if it is alone. But if it is found in the CTG, you will be reassured that baby heart rate is okay. Okay, so let me move with you to the next case, and this is the question number 6. In this question, there is a woman with short history of vaginal spotting and cramping, abdominal pain after 7 weeks of amenorrhea. A few days earlier, she had a positive result on home pregnancy test. The cervix is closed on examination. An ultrasound scan shows intrauterine gestational sac. A fetal pool with cardiac activity is seen. So what type of miscarriage is this? What's your diagnosis?
Threatened miscarriage.
Thank you very much, Dr. Marwa. Just please give a chance for your colleague to answer. Okay, guys, thank you very much. I really appreciate your activity. I'm so happy, okay, with your answers. But guys, I need you to participate actively, okay, in the discussion. So this is for the benefit of everyone. So guys, what do you think? You think that Dr. Marwa answer is correct? She answered threatened miscarriage. So is that right or no? Okay, thank you, Dr. Hassan. So yes, it is. Yes, correct. Thank you, Dr. Marwa again. So guys, how would you differentiate an exam between the types of miscarriage? Thank you, Dr. Angela. So there, we have threatened miscarriage. Threatened miscarriage will be defined, okay, by little vaginal bleeding with lower abdominal pain. By ultrasound, okay, they will be a fetal heart activity seen or a live fetus. Cervix should be closed, so you will diagnose threatened miscarriage. In the past, okay, we used to advise the patient bed rest, but currently nothing to be done. The recommendation of the college is nothing to be done. Only the woman will call us if there is increase of the bleeding or any other signs of acute pain or anything wrong. Otherwise, threatened miscarriage, nothing. Okay? Inevitable miscarriage, okay? This is the difference between this one and the other one is the cervix. If the cervix is open, okay? Still there is a live fetus inside, but cervix is open in early pregnancy cases. That eventually will end by miscarriage because the cervix is open, right? So the inevitable abortion can come after a threatened miscarriage or sometimes comes without any warning. What action is needed now for the inevitable abortion or miscarriage, sorry? For the inevitable miscarriage, no action done. It's a conservative, okay? So we will wait and see. If the woman develops severe bleeding, okay, especially those who have gestational age above 12 weeks actually can present with bleeding, considerable amount of bleeding, like 16 weeks or something like that. with the inevitable miscarriage. So in this case, will you say, no, there is a live fetus inside, I will not evacuate the uterus? Or you should go and evacuate the uterus, make your arrangement to evacuate the uterus to save the woman life? It will be saving the woman life. So inevitable miscarriage, either conservative or either evacuation or intervention, if only intervention, if only there is a severe bleeding. Otherwise, nothing, conservative. Missed the miscarriage. And in the missed miscarriage, you can see I have here just colored the keyword under each type of miscarriage. But in missed miscarriage, I have made for you the important highlighted points in the single best answers. When you can diagnose that this miscarriage is a missed. If a woman come to you and she tell you that she is having amenorrhea for 8 weeks, and you find that the gestational sac diameter is 20 millimeter and no fetal ball seen or no fetal activity as well. So in this case, will you consider this as a missed miscarriage because she is 8-week amenorrhea, or you will ask her to come after 1 week to repeat the scan? What you will do? Guys, I'm in need to your answers, please. The mean gestational sac diameter is 20. The period of amenorrhea is 8 weeks. So what do you think?
Wait for 1 week.
Yes, you will wait for 1 week. Excellent, dear. Thank you for your answer. That's because she didn't reach, okay, the cutoff of the gestational sac diameter. Even with the period of amenorrhea 8 weeks, yes, even of the period of amenorrhea 8 weeks. We don't look in the diagnosis of missed miscarriage to the period of amenorrhea alone. We look to the finding. We see intrauterine pregnancy, but it does not, okay, continue to grow. How? If you find a mean gestational sac diameter 25 millimeter or more with no yolk sac, this is indicate a missed miscarriage. Or you have a fetal ball with a crown rump length of 7 millimeter or more without fetal heart activity. This will be a diagnosis of missed miscarriage. In all cases, guys, you need to do the scan by the TVS. Okay, you cannot take any decision based on the abdominal, transabdominal ultrasound alone. You need to do a TVS. Okay, so you will make sure that this is the correct or this is the best image you get. Okay, so what is the recommendation of the NICE guideline? The recommendation is to repeat the scan after 1 week to confirm the fetal loss. Okay, we have a complete miscarriage, and in the complete miscarriage, all the pregnancy content are out already. Okay, so the question comes in the exam, ask you after complete miscarriage about what is the action needed. What will be the action needed, guys, now after a complete miscarriage? Do you need to do ultrasound scan after complete miscarriage? No, actually no need. Only the advice is to ask the woman to have a urine pregnancy test, the urine pregnancy test at home after 3 weeks. And even if she developed any signs of infection, foul smelling, bleeding, abdominal pain, okay, then she come to us. Otherwise, if everything is okay, bleeding stopped, okay, just do one UBT test. If it is negative after the 3 weeks, then it's done, it's finished. Okay, so no action needed for the complete miscarriage. Only UBT after 3 weeks. For the incomplete miscarriage, incomplete means that some products are out and some products are still in the uterus. What is the problem with incomplete miscarriage? The problem actually with the incomplete miscarriage is that we have risk of infection and risk of bleeding. Okay, so what is the action to be done? It's according to the general finding, okay, and severity of bleeding. If the woman is okay and there is only some products are there, no significant bleeding, then conservative. If there is a severe bleeding, then please do DNC. Okay, and if there is infection, you need to cover by antibiotic and do DNC. Okay, guys? One small question before we go. Ask you about the single largest cause of miscarriage that account of 50% of all cases. So what do you think? What will be the cause? Is it infection, smoking, chromosomal abnormalities?
Chromosomal abnormality.
Yes, excellent. So it's the chromosomal abnormalities, okay, that make 50% of all cases. So sad that we came to the end of our session today. Okay, so guys, our next meeting, I'm so sorry that I have to leave as well. Our next meeting, we will start by discussion of pregnancy of unknown location and have some labor revision, okay, the stages of labor, plus solving cases of labor and CTG, and some cases also of the obstetric complication. I'm preparing notes, okay, with flashcards for you guys, so you can remember the important numbers in the OBS and gynae. Specific this obstetric part that they are very common in your exam. The Vbac notes is ready already to make, so I'm going to share it on the group, okay? But I'm going to complete a note with all the numbers in the obstetric related to obstetric, like this number of today we have lactate level, okay? If it is more than 4, it indicates septic shock. If it is more than 2, indicate severe sepsis. Number also of the Mu's, the cutoff of the Mu chart, okay, when the score is 6 or more. And we have the number of the chromosomal causes of miscarriage, right? So we have some important numbers today, right? So I need you guys to remember this, okay? And once I finish the notes, I'm going to post it in your group, okay? And those are the Vbac notes with the success rate and the complication also rate, okay? I'm going to share it with you, okay? Because here comes the most important part of the exam about the overall success rate of planned Vbac, success rate of preterm Vbac, previous successful vaginal birth, induced Vbac, or previous CS due to labor dystocia, previous CS due to fetal distress, previous CS due to breech. Okay. Okay, so also wait my miscarriage notes. Okay, so this will be guidance for you guys into your exam and your practice as well. Thank you very much.